Say a patient presents to us complaining of proximal muscle weakness. Bilaterally, it's symmetric proximal muscle weakness. Not pain, not tenderness, not stiff, but weakness. What do we think about? Polymyositis and dermatomyositis. Good. What else? Inclusion body myositis also does fall into this realm, but something different about inclusion body myositis. It's not going to be just proximal, it's going to be proximal and distal. In fact, when it comes to inclusion body myositis, and a key difference between polydermatomyositis versus inclusion body myositis, one key difference is proximal and distal. Apart from that is timeline. What are you going to do when you have this suspicion from a lab test perspective? You can get inflammatory markers, but something else, because you're saying it's a myositis, meaning your muscles are going to break down. You're going to check for CK. CK is going to be elevated, right? So your CPK is going to be elevated in this patient in the thousands, right? More than how much CPK are you concerned normally? But CPK is going to be elevated in these patients, right? Is that good enough for diagnosis? No. So how are you going to diagnose? You need to biopsy, right? So question is, can you just straight up jump and what are you going to biopsy? You typically want to biopsy the muscle that's involved, right? But you don't know which part of the muscle that is affected. So you just blindly going and biopsying something might not give you the answer. So can you do some form of imaging to point and say, hey, let's biopsy this specific spot? Now, what is an important thing to differ between poly and dermatomyositis? What does dermatomyositis have that poly doesn't? Skin features. What are the skin changes? There's 6 of them, you need to know. It used to be 3, but now we got 6. Because everybody got comfortable with the 3. Okay, heliotrope lash, which is basically they're going to tell you the patient's eyelid is going to look purple, like somebody punched them in the eyes or something, okay? The eyelids are going to look edematous and purple, that's known as heliotrope rash. What else? Gautrens papule, which is classically seen in your knuckles, but it can also happen in the elbows and knees. So they can confuse you and give you a picture of a heliotrope, of a Gautrens papule that actually happens around your elbows and knees as well. Okay, but classically it's going to be in the knuckles. What else? Mechanic's hand. What is that?
Fissures around the lateral.
Fissuring around the lateral aspect of your fingers. That's what's called a mechanic's hand. What else? What is so important about polymyositis and dermatomyositis, apart from causing muscle weakness, which is a problem, right? What else should we be worried about in these patients?
Cancer.
Huh? They're prone for cancer. Okay, they're prone for cancer. What type of cancer? Huh? There's a few different types of cancer you should screen them for, but the boards can also tell you, well, screen them for age-appropriate cancers. They will like to give you this broad line, but if they actually want to go for specific cancers, it increases its risk for what cancers?
Colon.
Let's start from the top. Lungs, stomach, pancreas, colon, ovarian, lymphoma. Okay? It's like the best mnemonic you can ever get.
It's all over.
No, it's lung, stomach, pancreas, colon, ovarian, lymphoma. That's it. Okay? So those are the cancers that you want to screen those patients for. Dermatopolymyositis. Say you have a patient in the hospital, you've suspected, you've biopsied, comes back positive. How are you going to treat him? Steroids. You're going to start them on steroids. Okay? You can do 1 mg per kg, oral steroids, you'll start them on it, and you watch and see how they do. Typically, if they're responding well to treatment, say you have somebody with steroids, okay, and your CPK was elevated, say 50,000, 60,000, you start them on it, it improves good enough, it drops down below 5,000, you're comfortable discharging the patient, you discharge them out. And, the patient comes back to the clinic. At this point, if the patient is still complaining, saying, hey, I got more weakness at this point, okay, and you check the CPK, but the CPK is negative, what would you think of is going on? What about inclusion body myositis? How do you treat it? Does it respond well to steroids? No, it actually does not respond well to steroids. So much so, sometimes they say you can actually use IVIG on those patients. And another important feature with inclusion body myositis is what? Apart from affecting both proximal and distal, it actually affects your cricopharyngeal muscles. So they can actually come with a lot of dysphagia and aspiration. Okay, almost 50% of patients with inclusion body are going to have cricopharyngeal muscle involvement. Thank you for watching. If you like our content, please like this video, subscribe to our channel and hit the bell icon so you get notified when a video is released every week. Have fun studying. We'll see you on the next one.